Loop Diuretics explained: Furosemide, Bumetanide, and Torsemide. A patient with decompensated heart failure arrives with 20 pounds of fluid, bilateral leg edema to the knees, and oxygen saturation of 88% on room air from pulmonary edema. You order IV furosemide. Within an hour, they've urinated 2 liters and their oxygen improves. How did a single drug do that? Welcome to Medical Sciences Unfolded. Loop diuretics are among the most powerful and most prescribed medications in clinical medicine. Furosemide alone is one of the most commonly used drugs worldwide. Understanding their mechanism is essential for any clinician. The loop of Henle is a hairpin-shaped segment of the nephron that descends into the medulla and ascends back to the cortex. The thick ascending limb, the TAL, is uniquely impermeable to water, but actively reabsorbs sodium, potassium, and chloride via the NAK2Cl cotransporter, the NKCC2, on the luminal membrane. This reabsorption generates the hyperosmotic medullary gradient that is essential for water reabsorption in the collecting duct and urine concentration. Approximately 25% of filtered sodium is reabsorbed in the TAL. Loop diuretics, furosemide, bumetanide, torsemide, and ethacrynic acid work by competitively binding to the chloride site of the NKCC2 cotransporter in the thick ascending limb, blocking all 3 ion reabsorption simultaneously. This is the most powerful diuretic action available in the nephron, because the TAL handles the largest single fraction of sodium reabsorption and because downstream segments cannot compensate for such a large delivery of sodium. The consequences of NKCC2 blockade are profound. Sodium, chloride, potassium, calcium, and magnesium all fail to be reabsorbed in the TAL and flood the distal nephron. The distal tubule and collecting duct can only reabsorb a fraction of this massive sodium load. The result? High urine output with large losses of sodium, potassium, chloride, magnesium, and calcium, the electrolyte profile of loop diuretic use. The medullary gradient is disrupted. The kidney temporarily loses its ability to concentrate urine maximally. This is called washout of the medullary gradient, a reversible effect that contributes to the diuresis.
Beyond their diuretic action, loop diuretics have rapid venodilatory effects when given intravenously, reducing venous preload within minutes by dilating capacitance vessels, even before significant diuresis begins. This is why IV furosemide provides immediate relief of pulmonary edema in heart failure. The venodilation reduces cardiac filling pressures before a single extra milliliter of urine is produced. Furosemide is the prototype. It is approximately 50% bioavailable orally. Absorption is variable, particularly in gut edema from heart failure, which is why IV dosing is preferred in acute decompensation. It is highly protein-bound to albumin and must be secreted into the tubular lumen via organic anion transporters in the proximal tubule to reach its luminal target. In hypocalcemia, or with competing drugs, tubular delivery is impaired, a common cause of apparent furosemide resistance. Bumetanide is 40 times more potent than furosemide milligram for milligram and has more predictable oral bioavailability. Torsemide has the best oral bioavailability of the class at over 80% and a longer duration of action. Ethacrynic acid is the only loop diuretic not derived from sulfonamide chemistry, making it the agent of choice when a true sulfa allergy precludes the others. Key electrolyte consequences and monitoring. Hypokalemia, the most common side effect, results from increased sodium delivery to the collecting duct, where aldosterone drives sodium reabsorption in exchange for potassium and hydrogen. Hypomagnesemia follows from reduced TAL magnesium reabsorption. Hyponatremia can occur. Hypocalcemia, unlike thiazides, which reabsorb calcium, loop diuretics waste calcium, making them useful in hypercalcemia of malignancy. Metabolic alkalosis occurs because hydrogen ion losses accompany potassium secretion in the collecting duct. Contraction alkalosis also develops as the ECF volume contracts. Ototoxicity. Sensory neural hearing loss is a rare but serious adverse effect, most common with rapid IV administration of high doses or in combination with aminoglycoside antibiotics. The mechanism involves disruption of the endolymph ion transport in the stria vascularis of the cochlea, which also expresses NKCC cotransporters. Clinical uses: acute pulmonary edema in heart failure, chronic heart failure management, hepatic cirrhosis with ascites, nephrotic syndrome, hypercalcemia, and hypertension when other agents are inadequate. The combination of a loop diuretic with a thiazide, sequential nephron blockade, produces synergistic diuresis for diuretic-resistant patients. Thank you for watching Medical Sciences Unfolded.